All right. Thank you. Okay. All right. So thank you for asking me to speak this afternoon about chronic leukemias. And the talk will be divided in two parts. First, we'll talk about chronic lymphoid leukemias, and secondly, talk about chronic myeloid leukemias. Can everybody hear me and see my slides? Yes?
Yes. Yes, we can.
Okay, so the learning objectives for the first part of the talk will be to review how we diagnose the various chronic lymphoid leukemias, how we stage patients, how we make decisions about treatment, and a little bit about prognosis. We will spend a lot of time talking about B-cell CLL because it's common, say a few words about small lymphocytic lymphoma, and then review the entity called monoclonal B-cell lymphocytosis, say a few words about hairy cell leukemia, and then also talk about the T-cell leukemias. So B-cell chronic lymphocytic leukemia is the most common leukemia in adults in Western countries. And there is a male predominance, with the average age at diagnosis being 72 years of age. So I'm going to present three cases. And as we go through the talk and think about these three cases and how you would classify them and whether they need treatment and what the prognosis is. So the first is a 50-year-old man who's referred to you for a white count of 11,000 with 40% lymphocytes. His hemoglobin is 14 and his platelets are 350,000. Second case is a 65-year-old man referred for a white count of 18,000 with 50% lymphocytes. His hemoglobin is 13.5 and his platelets are 202,000. And finally, there is a 75-year-old woman referred for a white blood cell count of 30,000 with 60% lymphocytes. Her hemoglobin is 11, but her platelets are only 95,000. So this is a typical peripheral blood smear of a patient with CLL. You will notice that the only white cells on this smear are small lymphocytes. There aren't any neutrophils on the field. There are a few platelets, but the lymphocytes are small and rather mature looking. They're a little bit bigger, but not that much bigger than the surrounding red blood cells. This is another slide of a patient with B-cell CLL. And what you will see here, in addition to the round, regular, mature looking lymphocytes, are these funny looking bodies, which are smudge cells, or sometimes called basket cells. And these are an in vitro phenomenon that you see in CLL lymphocytes because they're fragile and they break up in the preparation of the blood smears. This is another slide of a patient with CLL. You see many, many basket cells or smudge cells on this field. Now, this you may think is a bone marrow, but it's actually not. It's actually a peripheral blood smear of a patient with an extreme lymphocytosis from CLL. And again, in addition to a lot of smudge cells here and there, you don't see very many, if at all, neutrophils or bands. And there are very few platelets as well. So how do we make the diagnosis of CLL? Well, it's actually fairly simple these days, because peripheral blood flow cytometry gives us the diagnosis very easily. So if a patient has more than 5,000 monoclonal B lymphocytes by peripheral blood flow cytometry, then the diagnosis of CLL is made. On flow cytometry, these cells are CD5 positive, CD20 positive, and CD19 positive. So the diagnosis is pretty simple. If you go back to our first patient case, that patient had a leukocytosis and a little bit of a lymphocytosis, but he did not have an absolute lymphocyte count of 5,000. So by definition, he can't have CLL. He may have something else, but it's not CLL. The other workup that we may do in a patient who has CLL are quantitative immunoglobulins, because many of these patients have hypogammaglobulinemia and are at risk for bacterial infections. And sometimes they're given IVIG because of recurrent infections, usually pneumonias or sinus type infections. Immunoelectrophoresis and immunofixation may reveal monoclonal protein spikes in these patients, usually IgG, but sometimes IgM as well. And about 10% of patients with CLL have a Coombs positive test result. A fewer percentage than that actually have hemolysis, but those patients would be expected to have a low haptoglobin, high LDH, and a high retic count. The beta-2 microglobulin, LDH, and uric acid may be elevated in patients with extreme lymphocytosis. FISH and cytogenetics are useful in prognostication for patients with CLL, and we'll talk about that a little bit later. Bone marrow biopsy is actually not necessary for the diagnosis of CLL because, as I mentioned before, the peripheral blood flow cytometry gives us the diagnosis. It's done in certain circumstances, one of which would be if a patient has, for instance, thrombocytopenia out of proportion to their hemoglobin and hematocrit and their white cell count. You may wonder if the patient has an autoimmune thrombocytopenia versus thrombocytopenia because of infiltration of their bone marrows by CLL. So doing a bone marrow biopsy may be helpful in a situation like that. Imaging isn't really necessary in working up patients with CLL. Physical exam, of course, will give you information about lymphadenopathy or hepatosplenomegaly, but you may want to do the imaging, particularly of the spleen, as a baseline and something to follow. So how do we stage patients with CLL? The Rye staging system is what's commonly used in the United States. The Binet system is more used in Europe. But the Rye system, which we use here, ranges from stage 0 to stage 4. Patients with lymphocytosis and or more than 40% lymphocytes in the bone marrow, monoclonal 5,000 monoclonal B lymphocytes, have stage 0 CLL. If they have lymphadenopathy, which can be by physical exam, doesn't require imaging, have stage 1 disease. Patients who have splenomegaly, hepatomegaly, or both have stage 2 disease. And patients who develop anemia have stage 3 disease, and patients with thrombocytopenia have stage 4 disease. The Binet system is a little bit different, goes from A to B. And again, it classifies patients according to their hemoglobins, their platelet counts, and whether they have enlarged lymph nodes or hepatosplenomegaly. So let's go back to our cases for a minute. I already mentioned to you my feeling that the patient with an absolute lymphocyte count of only 4,400 can't by definition have CLL. The middle patient has a white count of 9,000, a lymphocyte count of 9,000. So if we can prove that these are monoclonal B cell lymphocytes, then he has CLL by definition. The third patient has a much higher lymphocyte count, and assuming that they're B lymphocytes, she has CLL as well, but she has thrombocytopenia. So this is a different patient. And this patient, as we'll talk about in a few minutes, most likely does have indications for starting treatment. So early stage CLL, either Rye0 or Binet A stage, do very well. And they have a median life expectancy of 13 years. And normally those patients are not treated and they're just followed because they tend to do very well. The intermediate stage CLL, the Rye1-2 and the Binet B, have a life expectancy that's shorter. It's estimated to be around 8 years. And they are treated if they have what we call active disease. Patients with advanced stage CLL with anemia and thrombocytopenia don't do well unless they're treated. And we do have modern treatments that can certainly help these patients and recommended for treatment in pretty much all cases. So what about the early stage patients with CLL, the low to intermediate risk patients, the Rye0 to 1 and 2? They're treated if they have disease-related symptoms, if they have B symptoms, if they have weight loss, if they have fatigue, if they have night sweats, or if they have progressive bulky disease. Some patients have bulky lymphadenopathy in their neck or in the axilla, which can sometimes be unsightly and uncomfortable to the patient. So that in itself may be an indication for treatment. The lymphocyte doubling time less than 6 months used to be a criteria for starting treatment with CLL, but it's kind of fallen out of favor, and it's really not used very much in clinical practice. Patients who look like they're developing progressive anemia or thrombocytopenia and going into stage 3 or 4 may be looking at starting treatment. And patients with steroid refractory autoimmune cytopenias, whether it's an autoimmune hemolytic anemia or autoimmune thrombocytopenia, are candidates for starting anti-CLL treatment. And as I mentioned before, the high-risk CLL patients, the RY234 patients with progressive cytopenias with hemoglobins less than 10 or 11 and platelets less than 100,000 should be treated. So there are some other criteria, some other parameters that are useful in estimating how a patient is going to do. Patients with unmutated immunoglobulin variable heavy chain, patients with high lymphocyte counts, and patients with palpable nodes may have a shorter time to first treatment, depending on how many of these criteria they manifest. International Prognostic Index for CLL has a number of prognostic factors, such as deletion 17p or TP53 deletion, which is a rather poor prognostic variable. Patients who have unmutated IGVH genes are also looking at a poorer prognosis. Patients with high beta-2 microglobulins, sorry for the typo, and who are RISE stage 1 to 4, and patients who are over the age of 65 do get points for poor prognosis. So if you count all the unfavorable characteristics, you can put the patient into low, intermediate, or high risk, or very high risk for needing treatment over the first 4 years after they're diagnosed. We have some additional prognostic markers that can be used, not all of which are in clinical practice, but the TP53 wild type, the mutated IGVH are good prognostic indicators. Patients who on flow cytometry have less than 30% CD38, who have SAP70 and CD49D are also rather favorable. When you do cytogenetics in patients with CLL and you find deletion 13q as the sole abnormality, that's a good prognostic indicator. Patients who have normal cytogenetics or trisomy 12 are rather neutral. It's not unfavorable, but it's not favorable either. The patients with unfavorable characteristics are the opposites of the favorable group, as you might expect. And certainly there are cytogenetic criteria such as deletion 11q and deletion 17p, which are unfavorable characteristics. And any patient who has a complex karyotype with greater than or equal to 3 unrelated chromosomal abnormalities in more than one cell have a poor prognostic expectation. So how do we treat CLL in 2022? The class of drugs of choice has up to now been the Btk inhibitors, and this stands for Bruton tyrosine kinase, which is a B cell receptor signaling pathway for the growth and survival of B cells. So ibrutinib was the original Btk inhibitor. It's been followed by a number of related drugs, such as acalabrutinib and zanubrutinib. Monoclonal antibodies have also been used in treatment for CLL. Rituximab, which is our first and probably best known anti-CD20 monoclonal antibody, is actually not terribly effective in CLL, but obinutuzumab and ofatumumab, which are newer drugs on the market, seem to be a little bit more effective. And there is a BCL2 inhibitor called Venetoclax, which has been used in combination with the Btk inhibitors and is highly effective in patients with CLL. And the PI3K inhibitors, such as the drugs listed here, are also sometimes used, not usually as first line, but as second or third line in patients with CLL. So how do we decide which patient is fit for which treatment? So patients who are over 65 years of age, who are frail or who are younger and they have comorbidities, are usually treated with single agent ibrutinib, or they may be offered acalabrutinib with or without obinutuzumab, or venetoclax with or without or with obinutuzumab. And there are a number of other regimens that have been used in the past, which are older regimens, such as bendamustine, chlorambucil, high-dose methylprednisolone, and rituximab. Patients who are under 65 and who don't have any significant comorbidities can be treated with similar combinations. They've also been treated in the past with a regimen called FCR, which stands for fludarabine, cyclophosphamide, and rituximab, which has the advantage of a shorter defined course of treatment after which treatment can be stopped, as opposed to ibrutinib and its related drugs, which tend to require long-term treatment. The patients who have CLL with deletion 17p or TP53 have a poor prognosis, so they're usually treated more aggressively. They may respond well to ibrutinib, but they may also be offered combinations, as mentioned here. Venetoclax is a popular drug in treatment of CLL. It does have management problems. It's associated not only with hematologic toxicity, but a high likelihood of tumor lysis in treatment for many lymphoid malignancies, and is usually ramp up dosage schedule.
So June 2nd is Thursday. Yeah.
So ideally,
So you want them
like
off
not the
Thursday and
Wednesday
Friday.
night, if there are any like night shifts, and the Thursday.
I'm going to turn now to say a few words about small B-cell lymphocytic lymphoma. And you may wonder why that's in this talk, because the talk is supposed to be about leukemias. It's because small cell lymphocytic lymphoma, or SLL, is the type of lymph node pathology that you would see in B-cell CLL. So if you do a lymph node biopsy on a patient with CLL, it will be read out by the pathologist as small B-cell lymphocytic lymphoma. It has exactly the same immunophenotype as CLL, and it's the terminology that's used when there's no peripheral blood criteria for CLL. So it's possible that our first patient that we presented, who had a lymphocytosis but not enough absolute lymphocyte count to have to meet criteria for B-cell CLL, if he had lymphadenopathy and he had a lymph node biopsy, he might actually turn out to have small B-cell lymphocytic lymphoma instead of CLL. It's a little bit of semantics, but it's important to know that if the pathologist doesn't know the patient has a lymphocytosis, the report is going to say small B-cell lymphocytic lymphoma. I'm going to say a few words now about monoclonal B-cell lymphocytosis. This is a diagnosis that we make when a patient has less than 5,000 monoclonal B lymphocytes on flow cytometry. And the more flow cytometry we do, the more patients we find with small numbers of monoclonal B lymphocytes, which otherwise look like CLL lymphocytes, but do not meet criteria for CLL because the numbers don't reach 5,000. To make this diagnosis, patients must not have any lymphadenopathy, they must not be anemic or thrombocytopenic, and shouldn't have any organomegaly or systemic symptoms. So we believe this is a likely precursor to CLL, similar to what MGUS is for multiple myeloma. And the MBL patients have been divided into high-risk MBL, those patients who have a high monoclonal lymphocyte count greater than 500, and they behave similar to Rye stage 0 CLL. Patients who are called low-risk MBL have less than 5,000 clonal B lymphocytes, and these patients may never progress at all. So it is important not to label these patients as CLL because they don't meet criteria. Most importantly, this first criteria here. But they are followed, and some of them develop CLL as time goes on. To say a few words now about this entity. which I think probably most of you can name by looking at these lymphoid cells with these hairy projections. So this is hairy cell leukemia. And hairy cell leukemia comprises about 2% of all leukemias, but less than 1% of lymphoid neoplasms. So it's quite rare. These patients usually present with splenomegaly and cytopenias. And if you do a bone marrow aspiration on these patients, it's usually what we call a dry tap. So no bone marrow can be actually aspirated, and the diagnosis is made on the bone marrow biopsy. These cells arise from late activated memory B cells. On their immunophenotype testing shows that they have pan B cell markers. They're positive for CD19, CD20, CD22, plus CD103. And they have a BRAF V600E mutation in many cases. And they're treated with the purine analog cladribine or with a drug called pentostatin. And these patients actually do quite well, at least in the short to medium run, with response rates of over 90%, with a median progression-free survival of approximately 11 years. I've spent most of the time talking about B-cell chronic lymphocytic leukemias, but there are T-cell CLLs as well. And T-cell CLL is thought to be a small cell variant of T-cell prolymphocytic leukemia. On flow cytometry, they have completely different markers from the B-cell populations. They're positive for CD3, CD7, and CD45. They may be indolent, such as B-cell CLLs may be indolent, but they may be aggressive in nature as well. We can't use any of the anti-B-cell therapies that we use for the B-cell population, so they're usually treated with conventional chemotherapy, cytotoxic chemotherapy, and sometimes they respond to alemtuzumab. And some of these patients may actually end up with stem cell transplants. This is an example of a patient with T-cell CLL. If you remember the original slide that I showed, most of the B-cell CLL patients were smaller than these cells. They had pretty round nuclei, and they didn't have these indented nuclear patterns that some of the T-cell CLLs have. So they look a little bit different, even to the non-flow cytometry eye. There is another entity entitled T-cell large granular leukemia, or T-cell Lgl. These patients may present with a leukocytosis, or they may present with a leukopenia. On immunophenotyping, they type for B-cell, for T-cell with CD2, CD7, and bright CD45. They characteristically have a T-cell receptor gene rearrangement beta, and may be associated in some cases with pure red cell aplasia. So some of these patients with pure red cell aplasia actually have autoimmune relation, so that they may have rheumatoid arthritis or other connective tissue diseases, or they may not be related to any autoimmune condition as well. So if they have a leukocytosis, they are treated with cyclophosphamide. If they have an autoimmune pure red cell aplasia, they will respond usually to methotrexate. And if they have a non-autoimmune related pure red cell aplasia, they're often treated with cyclosporin A quite successfully. So this is an example of T-cell LGL. You can see the nuclei are rather indented. It's a little hard to see the granules, but I think there's an example of some granules here and maybe in this particular cell. So I just put some references on this screen about chronic lymphoid leukemias, but I will stop here for a couple minutes and see if any, before going on to CML, and see if anybody has any questions about the lymphoid leukemias before I go on. If not, I'll go ahead to the next part of the talk. So the second half of the talk is going to be on chronic myeloid leukemia, and pretty much the same learning objectives as we had for the first half of the talk. We'll talk about how we make the diagnosis, what are the staging criteria for CML, what treatment do we offer for these patients, and what is the prognosis. So another case presentation. A 35-year-old man is referred to you with a white count of 20,000. He has a hemoglobin of 15 and his platelets are high at 750,000. His differential shows 50% neutrophils, 10% bands, 5% metamyelocytes, 5% myelocytes, and 30% lymphocytes. When you talk to him, he says he's recently been experiencing some fatigue, but denies having any weight loss. On physical exam, he has no lymphadenopathy and his examination is otherwise normal, but his spleen is palpable 4 centimeters below his left costal margin. And this is what his peripheral blood smear would likely look like. You can notice that most of the white cells seen are neutrophils and bands. There are some larger, less mature looking cells that may be myelocytes, metamyelocytes, maybe even some blasts. And you'll also notice that in addition to the red blood cells, there really aren't any other cells such as lymphocytes. So this is a predominantly myeloid looking peripheral blood smear. But how do we know he has CLL, or what's in the differential? Because we really should try to think about what other possibilities he may have before we go farther into the workup. So could he have a leukemoid reaction? Certainly he could. People with leukemoid reactions can have extremely high white counts. They can go up to 100,000 or so. They're less likely to have the myelocytes and metamyelocytes that we're seeing in this patient's differential, but it's not impossible. I would say the major diagnoses that are in the differential for this patient are the other myeloproliferative neoplasms. So as you know, those are polycythemia vera, essential thrombocythemia, and primary myelofibrosis. So these are called the non-BCR-ABL myeloproliferative neoplasms. So could he have P. vera? Certainly patients with P. vera can have a leukocytosis and they can have a thrombocytosis. Generally speaking, they should have an elevated hemoglobin and hematocrit. But there are circumstances in which the patient doesn't have that, either because the patient has had some recent bleeding, patient might have iron deficiency, but he certainly could have P. vera. Could he have essential thrombocythemia? Yes, he could have that as well. To make that diagnosis, of course, you have to have thrombocytosis, and he does have that. And patients with ET can commonly have a leukocytosis as well. Could he have primary myelofibrosis? Well, a lot of us think of myelofibrosis as patients with splenomegaly and low blood counts, but there is a pre-fibrotic stage of myelofibrosis in which the counts are actually high, but they do have splenomegaly. So I think the other myeloproliferative neoplasms are certainly in the differential. We can do mutation testing markers for these myeloproliferative neoplasms. And as you may know, we look for the JAK2 mutation, the CalR mutation, and the MPL mutation. So patients with CML don't typically have any of those mutations, but if any of those mutations turn out positive, then these other myeloproliferative neoplasms certainly would be in the differential before you go into further workup. Chronic myelomonocytic leukemia does have some similarities to CML. It tends to occur in older patients, whereas CML tends to occur in younger populations. But patients with chronic myelomonocytic leukemia need to have an absolute monocyte count of greater than 1,000 and greater than 10% monocytes consistently for greater than 3 months. So there are some characteristics on flow cytometry that are consistent with CMML, and the bone marrow looks different than the patient with straightforward CML. There is an atypical CML category, in which patients otherwise look like CML in blood and bone marrow, but they lack the Philadelphia chromosome. There are also chronic eosinophilic leukemias and chronic neutrophilic leukemias who otherwise look like CML, but have particular predominance of eosinophils or neutrophils, and they have their own mutation characteristics. So we looked at this patient's peripheral blood smear or a blood smear of any patient with CML. This is what a CML bone marrow would look like. So the large cells in the center are, of course, megakaryocytes. And if you look around this bone marrow smear or bone marrow biopsy, you see a lot of myeloid-looking cells, neutrophils, bands. And what you don't see is you don't see many lymphoid cells and you don't see many erythroid precursors. This is quite a hypercellular marrow. There aren't any fat spaces, and this would be typical of a patient with CML. So how do we definitively diagnose CML? Well, we look for the Philadelphia chromosome, which is the 922 reciprocal translocation. And this is pathognomonic for patients with CML. So BCR-ABL is a fusion gene that results from the 922 translocation. And the ABL1 gene on chromosome 9q34 is translocated to the breakpoint cluster region, or BCR, on chromosome 22, giving us the name BCR-ABL. So this gene usually codes for the P210 fusion protein. Less often, it may code for the P190 protein or the P230 protein. The 190 protein is more commonly seen in Philadelphia chromosome positive ALL. It's an active tyrosine kinase. And luckily, with quantitative reverse transcriptase PCR, we can detect the transcripts that encode for these various products, the P190, the P210, and the P230. And after the diagnosis is made and a patient with CLL is being followed, it's actually very easy to do peripheral blood PCR testing for these transcripts as following their progress and whether they're staying in remission or not. So what about staging CML? So most of the patients that we see with CML present in chronic phase, like our case presentation. They have leukocytosis with or without thrombocytosis. They have 10% blasts in the bone marrow to qualify as being in chronic phase. And they have the 922 translocation, and BCR-ABL is found in these patients. So some 70, 80, maybe up to 90% of patients will present with chronic phase CML. They often have splenomegaly, but not necessarily. It's been said that patients who present with chronic phase CML who have significant splenomegaly have probably had the disease for several years, because the progression of splenomegaly tends to occur over years of disease. Patients with accelerated or advanced phase CML are those who have 15 to 29% myeloblasts in the blood or bone marrow, or greater than or equal to 30% blood myeloblasts and promyelocytes together, greater than 20% blood or bone marrow basophils, and platelet counts less than 100,000 that is unrelated to any therapy they've been getting for their CML. Patients who have clonal cytogenetic evolution are considered to be in accelerated phase as well. So patients with CML can go into blast crisis, and that's defined as patients who have greater than or equal to 30% myeloblasts in the blood or the bone marrow or both, or the presence of extramedullary disease. So extramedullary disease may occur in the skin or soft tissues. And if you biopsy one of these lesions and you see blasts in the biopsy specimen, that would be consistent with a blast crisis. And this is a photomicrograph of a bone marrow in a patient with CML with blast crisis. As you can tell, there are no longer neutrophils, bands, or even myelocytes, but there are a number of blasts here with large nuclei with multiple nucleoli, and this is very typical of a patient with CML and blast crisis. So how do we treat CML? Before we had CML-specific drugs, patients were treated with transplant. They were treated with allotransplant, and that's actually still curative, but it requires a matched, usually a sibling donor, and does have a lot of both transplant-related and treatment-related toxicity, and is not available to most patients who don't have such a donor. We can use cytoreductive agents such as hydroxyurea if a patient presents with an extreme leukocytosis. Hydroxyurea given for a couple of days before starting definitive treatment will bring the white count down. But the drugs of choice for CML are the tyrosine kinase inhibitors, and these are used for long-term control of disease. The first generation drug is imatinib, and it's still used today. There are second generation drugs called dasatinib, nilotinib, dasatinib, and busatinib. And they do give faster and deeper remissions than imatinib, but whether the long-term outcome is much different than with single agent imatinib is a little bit unclear at this time. Since CML tends to occur in a younger population rather than an older population, some patients with CML are going to be pregnant at presentation or become pregnant during the course of their disease. And those patients are treated with interferon because the TKI inhibitors are not used during pregnancy because of the risk of fetal damage. So what are the goals of treatment? So the first goal, of course, is to achieve clinical remission. And secondly, to maintain disease control with medication. And thirdly, to avoid progression to the accelerated or blast phase. The blast phase actually has a very poor prognosis. When patients are found to be in blast phase, they're usually started on a TKI inhibitor if they've not been treated with such before, or they're switched to a different class of TKI inhibitors with the attempt to get them back into chronic phase so that then they can go on to transplant. Just a few points about the TKI inhibitors, which are the mainstay of treatment in CML. All of the drugs are associated with hematologic toxicity, so patients need to be monitored to prevent cytopenias. But generally, they're pretty well tolerated. The long-term safety and the tolerability of imatinib is quite good, although there may be some GI side effects. Nilotinib is an interesting drug. It's a second generation TKI, and it's usually quite well tolerated subjectively, but it's got a unique set of toxicities. It's got metabolic effects. Patients can develop diabetes and hyperlipidemia, and it's associated with increased vascular complications, including acute MI, CAD, CVAs, and peripheral arterial disease. So these patients need to be assessed for their cardiovascular risk, and they may need to be treated with drug and lifestyle interventions, including smoking cessation. Dasatinib is well tolerated subjectively, but is associated with an increased risk of pleural effusions and occasionally with pulmonary arterial hypertension. And most older patients don't tolerate full doses of dasatinib, so they have to be dose reduced. Bosutinib is associated with GI problems and transaminitis. So what about the prognosis in CML? There are 3 scoring systems in widespread use. The Cell Cll score is most commonly used in this country, and points are given for age, size of spleen, platelet count, and percentage of blasts. And patients are categorized into low, intermediate, and high risk. The Euro score and the UTO score have slightly different criteria, but all 3 are helpful in choosing initial treatment and in estimating prognosis. So we have a number of response criteria in CML. The first is hematologic response. So a complete hematologic response would be those patients who, with treatment, gain a white cell count less than 10,000, less than 5% basophils, and must have no myelocytes, promyelocytes, or blasts on their peripheral blood in the differential. They must have a platelet count of less than 450,000, and their spleen must be non-palpable. But we can also look at cytogenetic responses. So A major cytogenetic response would be those patients who on reassessment had no Philadelphia chromosome positive metaphases and less than 1% BCR-ABL positivity. A patient who has no cytogenetic response are those patients who fail to clear any Philadelphia chromosome positive metaphases. And minor and minimal responses are somewhere in between. At 3 months of treatment, an optimal response would be a patient who has less than 10% BCR-ABL positivity and less than 35% Philadelphia chromosome positivity. A patient who at 3 months has not achieved a complete hematologic response or still has more than 95% Philadelphia chromosome positive patients has failed treatment and needs to be switched to a different drug. At 6 months, we expect that patients should have less than 1% BCR-ABL transcript positivity and no Philadelphia chromosome positivity. And the reason that this was these criteria were created was with the understanding that some patients do not have a complete response by 3 months, but may take up to 6 months to achieve that. At any time, a patient who has more than 1% BCR-ABL positivity or develops loss of complete hematologic remission or confirmed loss of molecular remission or new mutations is a failure of treatment. And there are further molecular characteristics that can be looked at. Major molecular response, or MMR, are patients who have less than 0.1% BCR-ABL positivity. And a deep molecular remission are those patients who have less than or equal to 0.01%. And this is actually the goal of treatment with patients with CML. The BCR-ABL kinase mutation, point mutations are detectable in approximately 50% of patients who fail treatment or who are progressing on treatment. And assaying for this mutation can be helpful in selection of subsequent TKI therapy for patients who don't respond adequately, because some of the TKIs are not effective in patients with this mutation analysis, and some are. It may also indicate patients who are at high risk of progression who need careful monitoring. What about stopping treatment in CML? So you may have noticed that I didn't talk about stopping treatment in the lymphoid leukemias, but there is interest in stopping treatment in patients with CML. And the reason for that is with current treatments, CML is now mostly a chronic disease with patient life expectancy approaching age-matched controls. So limiting treatment duration would avoid physical, psychological, and financial toxicity to these patients, and would eliminate the need to be on ongoing treatment for the rest of these patients' lives. Especially important since many of these patients are young and have other commitments on their time and their finances, of course. So this has been looked at for a number of years now, and the general criteria for stopping treatment, although you find that some authors have slight differences in approach. But if the patient has been on a TKI for at least 3 years and has been in a confirmed deep molecular remission for more than 1 to 2 years, should be considered or can be considered for stopping treatment. And it's a discussion between the physician and the patient, and involves joint decision-making, quality of life issues for the patients, et cetera. The patients need to be monitored very carefully, very closely if they're going to be taken off treatment. And the main way that we would monitor them would be by checking their BCR-ABL transcripts very frequently, at least at first. So it's been shown that 50% of patients who meet these criteria and go off treatment maintain treatment-free remission for many years. And it's also been found that most of the patients who do relapse regain response on resumption of therapy. So a very important criteria, which you may encounter patients who've been on treatment for CML and have gone off treatment and successfully stay in remission. So that's the end of my talk. A few more references for people to look at if they're interested. And started a little late, but finished right on time. So let me know if anybody has any questions or comments.
Thank you so much, Dr. Hawkins, for the great lecture. So if anyone has any questions right now, feel free to unmute yourselves or just write it down in the chat.
I can't see the chat from here, so Raphael, you'll have to tell me if anybody writes
Yes.
anything.
I'll let you know. So far, it seems like there are no further questions. But again, thank you so much for this lecture, for coming to our academic half days once again.